The CASTOR study is a study where patients who had 1 to 3 prior lines of therapy were randomized to receive bortezomib and dexamethasone versus bortezomib and dexamethasone with daratumumab. This study was published in the New England Journal of Medicine a couple of years ago, and based upon the study, the use of bortezomib, dexamethasone, and daratumumab as relapse therapy has been approved and is generally used in Canada. In Canada, we've had this combination since the beginning of 2019, so gradually we're accumulating experience on this. What was really important with the study is that it gives us the 4-year data on these patients, and it continues to show that patients who were on the study arm, which is bortezomib, dex, and daratumumab, continue to do extremely well. And in particular, those patients who received bortezomib, dex, daratumumab after 1 prior line of therapy, they do extremely well as well, and even better. So in general, patients who are on bortezomib, dexamethasone, and daratumumab tolerate the drugs extremely well, but there is a higher risk of neutropenia, and there is a higher risk of infection in these patients. And I think what that information has done to practicing clinicians like me is that it makes us a little bit more vigilant about these patients, such that we can watch and we treat them a little bit earlier than we might for other patients, because we know that they can develop these types of infections. Also, of course, with the added neutropenia that they can get, they also do need closer surveillance. For patients who have progressed on lenalidomide, this is an important option for patients because what it does is that it allows them to have a combination with different classes of agents. And I think it reassures the clinicians in general that these patients will do very well with this combination with manageable side effects. Of course, this does beg the question about other possible second-line therapies that can be used, and I think one has to look at the data extremely closely to choose one or the other. But I do think at this time there is a general feeling that a daratumumab-based regimen would be one that we preferred in this setting of patients who have progressed on lenalidomide up front.